So again, very good morning, and thanks to AIOC for inviting me for this conference. And sorry, Dr. Bhaskar sir, I'll have to speak the same talk before you. I was dreading speaking it after you, but now I get to speak it before you. So for all of those, all of us who are doing LASIKs or have done LASIKs, we know it's very simple. Unlike a cataract, you do a refraction. Most of the investigations that we do are to rule out outliers so that we don't land up with complications post-operatively. And then we generally ablate the refraction or we take out the lenticule, and that's how a simple LASIK works. The difference in topo-guided LASIK is that between refraction, or the number that we check, and the treatment that we do, now there's a machine that picks up all the diagnostic data of the curvature of the eye, the topography, and pushes this data onto the machine, and this data, for once, is now usable to not only treat the numbers, but also to make the cornea regular and more mathematical. So I'll start with this case over here. This is one of the few cases that I did in the beginning under with Dr. Rohit Shetty at Nara Netralaya back in 2011. So it's not like it's new, but this is what it was being used for. Keratoconus patient. I had to really fetch out this case. So this is an inferior cone, as you can see. The idea for treatment in this was not to give vision, but to halt the progression and, or more importantly, to regularize the cornea, but it had been a stable cone. So this is the topography, which shows you the cone. This is the ablation profile that is decided by the laser based on the topography data. And then if you superimpose the ablation onto the patient's cone, you will realize that the laser is going to fire in certain areas where it's going to thin the cornea and it's going to shave off the cone. So just to show you the impact of before surgery topography and after surgery. The entire coma or irregular aberration is converted into a regular corneal astigmatism, and such was the power of topo-guided treatments, or what it was called as TCAT many years ago. So again, to show you before and after. And again, same thing with the pentacams, showing the same thing. But interestingly, on the aberration profile, which is what matters and which is what we're looking at, a bad aberration profile on an aberrometry, you don't even have to know the machine, turns into a good post-operative astigmatism, which can be treated by many ways: glasses, contact lenses, or ICL, whatnot. So I'll just move out of this, again, to show you before and after of the same treatment. The question is, what happened? We looked at the topography and we treated the cornea based on topography. Now, later, a few years down the line, it started coming up as what is known as contour vision or topo-guided treatment. So we all realized that what we could do with bad eyes, we could do much better with eyes that are pristine and good. Not only treat the numbers, but make their corneas better. Again, a case scenario, just to show you a 20-year-old with stable refraction, slight anisometropia, and this is the preoperative topography. Like it was discussed in the previous study, I use a mix of Placido topography with shine plug because the anterior corneal curvature comes out better with Placido. And I decided to do a contour treatment on this patient. This is how the capture looks like. You get the pupil, you get the visual axis, and you get a lot of data. This data is then pushed onto the machine, onto the excimer laser, because it has a large number of points compared to a pentacam or any shine plug imaging, because it is a Placido, and Placido obviously has more curvatural data. This can be done by either networking or by a USB. And then you plan the patient's treatment, and you need a number of scans because you average out the scans, and then you decide what's going to be treated. So in this same patient, if you notice, this was the treatment. If I were to do a simple LASIK or a lenticule or whatnot, it would be an optimized treatment. Versus if I do a topo-guided treatment, the difference is this. Apart from removing the numbers, it's also going to shave your cornea in certain places a little more and a little less, so as to make an irregular cornea. Even in a regular, normal, pristine virgin eye, it will make it better, so that your vision becomes better. And this is true customization, which is, as of now, not available with any lenticule or any other LASIK formats, which do not have. So obviously not Contour, there are certain companies that also have topo-guided treatments, but such level of customization is still not available with any sort of lenticule extraction. What other things it does is it gives you centration on the visual axis, and it also compensates for cyclotorsion, which we all know as cataract surgeons and refractive surgeons. The eye rotates when we lie down, and so the ablation should also rotate to match the eye in order to give the right outcomes to the patient. Sometimes the pupil also shifts, which is called a pupil centroid shift, and it should also, machine ideally should be able to understand and compensate for all these. So what is Contura? You're removing glasses, which was the basics. You're also treating corneal irregularities because you're doing a topo-guided treatment. It's centered onto the visual axis, so it's right where it has to be. It's not on the apex of the cornea, and therefore it gives you a good vision. There are certain guidelines which are set up by the company, which tend to blur as you do more, and you tend to realize that you can play with this a little more. And this is to show you a before, and this is to show you after of the same patient. It's a very pristine cornea, very well balanced. The entire ablation profile is centered onto the pupil, and it's a very, very clear situation. That was a myopic LASIK. Now this is just to show you a hypermetropic, and hypermetropes are a big, situation. Whenever these patients turned up into our clinic, the amount of chair time that they take and the amount of investigation they take are huge. So this is the refraction. This is a close cycloplegic refraction, high hyperope. Everything else looks stable. There's a little bit of astigmatism. Again, everything unremarkable. But notice, so I did a contour on this patient and noticed post-operatively, if you can see a bump over here. So what essentially a hyperopic LASIK will do is it will take out a whole donut-shaped button from this area so as to dissociate the central cornea from peripheral cornea, and it will bump your central cornea so that it becomes like a lenticule in the center. So this is before and this is after of the same eye. This patient is now settled down with minus 0.75 and a minus 0.5, which is fairly good outcome, and I hope this patient doesn't decompensate, because post-atropinized also the patient was at a 5.5. But it goes to show you that these lasers can not only treat myopia and astigmatism excellently, but these topo-guided treatments can also treat hyperopias quite nicely. The only difference I do is in hyperopic LASIK, as I was told by one of the senior engineers, Ankur, is don't do it on the patient's visual axis, but try to do it on the center of the cornea, and I do value that point. So this is just to show you the data. This is a company slide, but to show you that in patients who the study did contour vision or topo-guided treatment, 60% patients were there at the same vision that they were seeing with glasses, but more than 30% patients saw one line or better in their vision as compared to their preoperative best corrected spectacle vision, which goes on to say that if you treat the patient's higher order aberrations and do all the minor details of doing it at the visual axis and keeping it centered, if the patient's resolution capacity is high, you can be able to make them see better than what they were regularly seeing with glasses. And obviously this goes for all sorts of vision, daytime, nighttime vision, reading, computer vision and whatnot, because it's a truly customized treatment, you can see better. There are many studies that have proven that topo-guided treatment gives you better visual outcomes. And I'm not going to read this in the interest of time and to save something for Dr. Bhaskar to talk about. Just going to finish off saying that if you look at topo-guided treatment, this is an age where everything is changing. The whole world of refractive surgery is changing into lenticule-based surgeries. But what we need to understand is the primary reason we are doing a surgery for patients is for vision. And when it comes to vision, if the more crisper you can treat, the better the patient's vision is. So in my hands, topo-guided treatment or contour vision works favorably, and almost all patients are very happy and comfortable within 24 hours of surgery, and most patients see more than one line at the end of the day. Thank you.